Welcome back. For those that are new to the channel, my name is Dr. Taylor. I'm a board-certified emergency medicine physician on staff at multiple different hospitals, ranging from small community hospitals to large academic trauma centers. In addition, I serve as a flight surgeon in the United States Air Force. So let's get right to it. We're going to be doing Season 1, Episode 4. I would argue that these critiques are probably the most extensive and in-depth critiques currently on YouTube by an ER doctor. We're going to be doing all 15 of the episodes this season before looking at a few other medical dramas. So again, if a medical drama is going to advertise itself as realistic, then I'm going to critique it as realistic. Let's go.
What the hell is going on out there?
Somebody stole a reg.
Again?
Hey, where do you think you're going?
We'll be back in 2 minutes, Max. Antoine's gonna show us his new motorcycle.
Great. We always need organ donors.
Ah, someone stole your rig.
Yeah, you weren't watching the screens? How'd you miss it?
Oh, I saw it pull out. But I figured you were in it. Why'd you leave the keys in it?
It's protocol.
No, it's not.
That's what I said.
Yes, it is. And who steals a fucking ambulance at 10 a.m.?
Easy. Junkies, meth heads thinking they just stole a candy store.
Or a psych patient kicked loose last night. And y'all don't know. That thing is getting stripped, chopped, and shit.
Hey,
That's
shut the fuck up. Maybe another driver took it. Did you call your dispatch?
Of course, we called our dispatch. Did you call the cops?
I can. But the two having breakfast in the cafeteria. Note to self.
Hey,
I'm good, thanks.
protocol.
So if you recall, episode 3 ended with someone stealing an ambulance out of the bay. Now, the story I gave briefly was that I was on shift, the patient was discharged, and they went and stole an ambulance out of the bay and attempted to pick up people, just random people, and try to take them to the hospital. So they were eventually caught, so the scene was definitely not dramatic for the TV. This is just plain accurate.
Jesus!
Okay.
There's something moving in there!
Man, hold still. I can't help you if you keep moving your head.
Get it fucking out! I can feel it!
Arthropod in the EAC.
So arthropod in the EAC just stands for external auditory canal.
Take a deep breath for me.
Jesus, everybody's going to this concert tonight. I wonder if there's any decent passes left.
Another deep breath.
So this is our Xanax accidental overdose laced with some kind of opiate off the street. At this point, she's basically being observed in the ER to see if she would need any more Narcan before safe discharge home.
Oh my God, Jenna. You're never gonna believe who DM'd me. I fucking told you this would happen.
I'm sure Jenna's happy you're here to support her, but perhaps you could wait outside until we finished.
Excuse me?
Excuse me, I'm in the middle of an examination.
Yeah, and I'm gonna stay with my friend for as long as she needs me. I'm the one who brought her here.
Gold star for you.
Okay, it's fine. I'm fine.
You sure?
Thank you. I wanted her to leave.
So Narcan or naloxone effects can last anywhere between 30 minutes up to 90 minutes, sometimes even longer than that. The half-life is roughly 60 minutes. Now, this is per the National Library of Medicine and University of Colorado. Now, if Narcan wears off before the effects of the opiates wear off, the patient might need a second round of Narcan as the respirations can start to decrease, pupils start to go back to pinpoint, and the patient slowly becomes more altered.
Good news or bad news first?
What's the good news?
Ear canal is numb. Simple flush with saline will fix the problem.
What's the bad news?
You've got a dead bug in your ear.
Cockroach.
Now, in the ER, we love a good foreign body, and that doesn't matter if this is a rectal foreign body, if this is a vaginal foreign body, a nose foreign body, an ear foreign body, pretty much any foreign body, any attending is going to pick this up, any resident is going to pick this up. And I've seen it all in terms of the ears, for example, peanuts to beads to Legos to bugs, the list goes on. Now, when we have a live bug, we really want to kill it first to limit any further damage to the ear canal, the tympanic membrane, really anything in general. So some common things that can be used include mineral oil and lidocaine. So in general, mineral oil is thought to coat the bug, causing asphyxiation and then death. And it may take a few seconds until it dies, where the bug actually can move around violently, causing more damage. Lidocaine, on the other hand, very similar to what we use when we do laceration repairs and things like that, so patients don't feel it, causes instant paralysis to the bug. Now, debate still exists on the best one to use, viscous lidocaine, lidocaine solution, mineral oil, etc. But the key thing is that the bug is killed first to limit damage.
Wendell Stone, 52, chief rigger from PITT Fest. Isolated shot to the left chest when a speaker tower came down on him. Looks like multiple rib fractures. Pulse 110, BP 130 over 85, decent stats at 96, 50 of fent in the field.
Got it?
How we doing, Mr. Stone?
Mr. Stone was my dad. Just Stone.
So just to recap this case, it's a 52-year-old that we're seeing. Status post a speaker tower falling on his chest at a festival as one of the crew members. So he's tachycardic at 110, blood pressure is 130, oxygen is normal at 96%. and he's given 50 micrograms of fentanyl prior to arrival via EMS in the field.
Mr. Driscoll, Mr. Doug Driscoll.
I'm fucking tired. See you later, suckers.
Excuse me.
Sorry.
Gia Yi Chin? I have some Tylenol for Gia Yi Chin. Yes, please. Over here.
Now, this patient has essentially appeared in every episode so far. He's in the waiting room for quite some time, and now he's finally getting called up.
No abdominal tenderness.
What do we got?
Thanks, you owe me a Coke.
Isolated chest trauma
Stop.
with...
I want to hear from Dr. Santos.
Isolated chest trauma with obvious flail chest. No human pneumo on POCUS. Good sats and vitals.
Excellent presentation.
So here they state flail chest with no pneumothorax on bedside ultrasound or POCUS, point of care ultrasound. And every single case so far, you know, we're relying on this bedside ultrasound to 100% rule out a pneumothorax based on only 2 locations, second intercostal space on both sides. Just get a chest x-ray already. I know I've mentioned this on a few other episodes, and we're actually going to deal with it a little bit later when we start talking about a pneumothorax and then some of the procedures and then ultimately the tension pneumothorax. And I think one of the reasons that we continue to see, you know, all of our decisions being based on only ultrasounding 2 locations instead of just doing an x-ray, I think we're seeing that only because you can't get a portable x-ray machine or anything realistic into the ER for sake of costs or anything like that. So that's totally fine, but I think that's kind of throwing things a little bit in terms of the decisions that are made, and we're having to improvise these cases. Now, she states no pneumothorax. Again, if she's only looking at 2 spots, second intercostal space on both sides, which seems common on the couple of scenes that happened so far, we're going to miss a small pneumothorax. Again, this is generally ultrasound guided in 2 to 3 spots in each lung to 100% rule it out. Again, some of the evidence will support linear transducer bedside ultrasound is more sensitive than x-ray in the detection of pneumothorax, but that's also based on ultrasounding in just more than 1 spot. So again, this is operator dependent as well. So if we're simply comparing x-ray versus ultrasounding 2 spots, just get an x-ray. It's fast, it's quick. All of these trauma beds have the ability to get an x-ray relatively pretty fast. And then we can immediately tell roughly how many ribs are broken, any obvious pneumothorax. So there's more info that we're going to get from here. Just get an x-ray. So what is a flailed chest? Rib fractures in at least 2 or more locations on the same rib and involving at least 3 rib fractures. What ends up happening is that you get this free-floating segment of ribs that's no longer attached to the rest of the thorax. Clinically, what you see is actually pretty cool when you see it in person. You can actually see this paradoxical movement of the affected segment, meaning you get inward movement of the involved portion during inspiration, and you get this outward movement during expiration. And so she likely stated flail chest here because she actually saw this movement, and you can actually see this when the patient's breathing. Now, as an ER attending, regardless of your point of care ultrasound, I'm still going to be getting a chest x-ray. You know, in this case, the patient had a flailed chest. They can see that segment. So you can mention likely it's 3 rib fractures, it's a flailed chest. That's fine, but what about the rest of the rib fractures? Maybe the patient has 6 to 7 rib fractures more on that side. You know, maybe the oxygen may be normal, but we also see pulmonary contusions with this and eventual respiratory failure. So likely this patient has an underlying pulmonary contusion, and given the length of time, if you did a chest x-ray or even, you know, obviously the CAT scan, the chest x-ray may pick up some of these abnormalities in the lungs that says, hey, this patient's actually got a flailed chest. They happen to also have 6 to 7 rib fractures, and they have scattered pulmonary contusions. They're at risk for respiratory failure. Just because the patient has no hypoxia does not mean you're not going to see pulmonary contusions. Again, just get a chest x-ray. It's going to show us so much more information. Now, the patient will eventually have a CAT scan that's going to be detailed, but at least just get an x-ray.
Sir, I'm Dr. Garcia from surgery.
I need surgery?
Not necessarily. No blood in the belly. I'm fast.
Okay, you got this?
Abdomen's benign. CT chest, abdomen, pelvis with contrast. Which I trust way more than your ultrasound skills.
Exit!
So after literally just stating the patient had a flailed chest, we watched the resident literally just push on the flailed chest. Anybody that's watching this, please don't do this. This was horrible. Don't push on it. If you've already made the diagnosis of a flailed chest based on that paradoxical movement that we talked about, which you can see in this patient, don't push on that chest. If that patient did not have a small pneumothorax based on the bedside linear transducer ultrasound in only 2 spots, because you just pushed on this chest, there's a chance that you also caused a pneumothorax on this one.
And more morphine, for God's sake.
No. Don't knock me out. I gotta stay on top of the crew doing the pudding.
The what?
The festival.
We'll block all the nerves going to the broken ribs. Roll to the right, pain-free.
Yeah, that's what I'm talking about.
That's a ton of intercostal blocks.
Nope, one shot. Serratus interior blocks down to T9.
You kids and your crazy regional blocks. Dr. Santos, call me with the CT results. Extension 1121.
So what he wants to do here is called a serratus anterior rib block. So this is a pain management procedure, and this is typically done by anesthesia. And the only reason I bring this up is because I don't do those. Now, I've got numerous emergency medicine residency friends. I texted numerous ones. I got 20 responses back, and they're all over the country. None of them do this particular block. So if anybody watching this right now is an ER doc that does serratus anterior rib blocks in the ER for rib fractures or a flail chest, please drop a comment. I just don't know anybody that does. The patient stated he did not want knocked out, which is why they suggested the block. However, you can give enough pain meds to help with the pain and not be knocked out. Remember, they gave him pain meds. EMS gave him pain meds en route, and likely if the patient agreed to that, he's going to agree to a second dose. So if anybody, again, is watching this right now, you're an ER doc, you do intercostal rib blocks for a flail chest, feel free to comment. Again, I just don't know anybody that does this. Also, as a side note, I think it's the liability of this case. Now, they never did a trauma chest x-ray, at least that we got to see, and knowing what we've kind of seen so far, I don't think any x-rays are done. One of the complications from this nerve block is a pneumothorax. Remember, at this point, the original point of care ultrasound done with a linear transducer, second intercostal space, they stated no pneumothorax. But since this point, we've also had a resident poking on the flail chest. Again, one of the rare complications from poking on that can be a pneumothorax. And then they proceed to do an intercostal rib block. Again, one of the complications of this can be a pneumothorax. And then it turns out that after doing the intercostal block, the patient has a small apical pneumothorax. You're going to get blamed for that pneumothorax related to that procedure. And again, I think at this point, just get an x-ray already.
Age that I was when we made our first layout. You remember that, Dad? The two-level track in the basement of the Clovis house? Oh. That's right. Yeah, it was an O gauge. It limited the cars we could use, but the layout was a beauty.
So this particular case, I did not review given the time. So my second review is 50 minutes. My third review was, 1 hour and 10 minutes. So I'm trying to shorten these. But at this point, the patient was extubated. They're actively dying. The patient was placed into a private room. And this is actually a pediatric room in the ER that was not being used. It was the only place that they had available.
Thank you. You were the best dad a boy could have wanted. You never missed a game. You always made time for me, whether to play catch or to build models or when help me with my homework. Or when we would wake up before everybody else and make sandwiches.
Here he actually starts to have flashbacks from COVID-19 because he was in that same room taking care of another patient, a colleague, a physician, and he was taking care of that patient in that exact same room just because of the high volume. And this is so realistic. You can be in one room and you have something happen. It doesn't matter what it is. Again, it could be a gunshot, stabbing, whatever it may be, and you pronounce somebody, and then let's say it was just a really, really bad case. And then the very next day, you're in that room and it's somebody else. It doesn't necessarily have to be a similar case. It can be completely unrelated. And it's like, you can look at that trauma floor and you're like, I can still see, in my mind, I can still see some of the blood on that floor, even though it's not there. Or, a few things in that room remind me of that case. And so you kind of have that flashback, and you're going to continue to have that. You're in one room, something happens. When you're in that room again, and that case was a very memorable case, rather a good memorable or a bad memorable, you're going to start having a little bit of PTSD, and this is completely normal. This is very realistic. This part of the ER is what makes this real. Realize this is only one person doing this, but this likely happens all around the hospital with every specialty, with nurses, techs, etc. Great job to the staff of the PITT for making this so real. Love it. So at this point, you have to refocus. Remember, this is hour number 4 of 15 hours. Now, we don't know if this is going to be a 15-hour shift like I talked about in episode 1. It's kind of unusual to have 15 hours. Generally, it's going to be an 8-hour shift. I've done 8-hour shifts, 9 hours, 10 hours. Last night, I did a 12-hour shift. So 15 is kind of odd. I did a 24-hour shift every now and then. But again, 15-hour shift is pretty odd. So maybe something's going to happen a little bit later that's just going to take us up to 15 hours. We don't definitively know if this is going to be a 15-hour shift. But realize you're at hour number 4 right now. You have dozens of patients still to see, and you need to refocus. In the ER, we actually force ourselves to compartmentalize and move on, which is exactly what he's doing in this case. Very realistic. I love this.
Okay.
So here we're getting back from CAT scan. Likely this was a CT with contrast, as that is our trauma study. And remember, this was after the initial point-of-care ultrasound said no pneumothorax. This is after poking on the chest, on the flail chest, said no pneumothorax. And this is also after the block itself, assuming no pneumothorax. So here she got a call from the radiologist, which is very normal to get a call for a critical finding. They typically don't call about a small pneumothorax. You're going to get a call from radiology typically for a large abnormality, like a leaking AAA, or you're going to get one for, an aortic dissection. You're going to get things for, kind of a critical finding. So in this case, the phone call was made likely this is a moderate to large pneumothorax.
How big is the pneumothorax? Got it, thanks.
What's a pneumothorax?
Just a little air leaking from the big bruise in your lung.
And here is the pneumothorax. Now, she asked how big on the phone, and we're not told, but likely it's a good size. She states it was from the bruising in the lung, which is also possible, as severe pulmonary contusion from blunt trauma can cause a pneumothorax. Or was this from pushing on the flail chest and the broken ribs actually punctured the lung? Was this from the procedure that was done itself? Or was this initially from the pneumothorax on arrival? Again, you have no x-ray prior to CT to prove any of this. If you have a linear transducer that was done in 2 spots even prior to the procedure or poking on the flail chest. A pneumothorax is defined as the presence of air between the parietal and visceral pleura of the lung, and this causes the lung to collapse. This can be either a simple pneumothorax or a tension pneumothorax, which we'll talk about a little bit later.
Getting short of breath here.
Pain?
No, all that's gone.
Good block worked.
Sats are down to 85 on 5 liters.
Right now, the vitals on the monitor, he's tachycardic at 115. Oxygen is 85% on 5 liters. Respiratory rate is actually normal at 16. So again, normal is anywhere between 12 to 20. So he's got a normal respiratory rate. And blood pressure is normal as well at 118/78. And he mentions he is short of breath.
His lung contusions need some help. Start BiPAP, 10/5. That'll open up the bruised parts of your lung.
The intern states here to place the patient on BiPAP. Big mistake. Remember, the patient's only on 5 liters. So you're either going to increase a few more liters and recheck the oxygen, or place the patient on a non-rebreather, but do not place a BiPAP here. If we wanted to decrease the work of breathing, and this was a non-pneumothorax setting like COPD or congestive heart failure, sure, BiPAP is fine. And at that time, though, the respiratory rate would likely be higher. This is a patient that comes in acute decompensated heart failure, or they're having a COPD exacerbation, and the respiratory rate is 30 to 40. We want to decrease that work of breathing in addition to providing oxygen. Then BiPAP is totally fine. The patient's respirations here are normal, and they only need to have the oxygen increased. So jumping directly from 5 liters to BiPAP is just not needed, and it's the wrong choice in this situation. Now here she is an intern, and the phrase we like to use in training is you don't know what you don't know. Remember, she is in training. She is a first-year intern. This is likely her first month in emergency medicine after just completing medical school. So she thought she was making the right call when in reality, she should have let her senior resident know about the situation, or even one of the trauma residents on rotation as well. She should have at least said, hey, by the way, the patient's hypoxic, they're on 5 liters, there's a good sized pneumothorax, what should I do? So here she places the patient on BiPAP. Now, she did multiple things here that are questionable. She should have notified her senior of the CT chest results, should have notified him of the oxygen, and then the senior resident would have gave his recommendations, like putting in a chest tube at this time, because now you're putting in a chest tube for a simple pneumothorax versus what we're going to see later is putting in a chest tube for a tension pneumothorax.
Thanks.
Good news is you don't need surgery, but I'll let Dr. Garcia know about the CT.
She likes you.
I met her 2 hours ago.
Must have made a strong first impression.
So the intern here is going to let the surgery resident know about the CT results, which is fine. But again, let your senior resident know who's also working that case with you those results as well. Realize that surgery resident may be nowhere near the ER. In fact, She could be in the operating room, or he could be in the operating room with another, with another patient. And so they may not be able to get to that patient. So just let your senior resident know. Now, if the surgery resident, is nearby, obviously let them know, but you're going to let your senior resident know that's a part of that case. While I'm critiquing this scene, it's not because it's inaccurate. It's actually because I've had to deal with this as one of the chief residents. So for a medical drama to incorporate this is actually amazing, and it's very accurate. Again, what they're depicting is something that can happen really anywhere, but specifically in a teaching hospital. So you kind of get to see the other side of things. Again, it's a teaching hospital. Mistakes are going to be made, but it's important that, we're correcting them, we're fixing them, we're addressing these things early on so that, bad things don't happen later. So let's talk about why BiPAP is contraindicated in this setting. So BiPAP, or bilevel positive airway pressure, is a non-invasive ventilation technique. If you've ever worn one, it feels like a waterfall of oxygen is hitting your face. While I was still a resident, we actually had a critical care course that involved all of us wearing a BiPAP, so we would know what it felt like when we put patients on BiPAP. BiPAP provides 2 levels of pressure. It has a positive airway pressure known as IPAP, which is also referred to as pressure support, and it's also got a positive air pressure referred to as EPAP, one during inspiration, one during expiration, basically delivering pressurized air into the lungs at different pressure levels based on whether the patient is inhaling or exhaling. The reason BiPAP is contraindicated in a simple pneumothorax is that it can progress to a tension pneumothorax, which is a severe life-threatening potential diagnosis that if we don't intervene fast, they can go into cardiac arrest and die.
So why are you sticking me again?
Came in an hour after the chest pain. It's a heart attack. It can take more time for the heart damage to show up in the blood. Put your finger on that. Even with the normal EKG, that's why we repeat the test.
So this patient has definitely been in the ER for a while now. Now realize, just because you're in the waiting room does not mean you don't get your vitals checked, repeat labs, EKG, etc. Those are going to get done. And if anything comes back abnormal, those things are being monitored, and you're going to get brought back into a room very fast. And so in this case, the patient's already had a normal EKG. The first troponin was normal. He was also called back. Likely this was for a second troponin. So things are continuing to progress. Again, it's not uncommon to get all this blood work. If anything comes back, the patient's going to get brought back. I've had patients before where they come in, generalized fatigue, weakness, vitals are all normal, and the patient's out in the waiting room. You get a lab back. Let's say the CBC, the hemoglobin, shows that it was 6.5. That patient's coming right back. And it turns out that was, an anemia related to a GI bleed. But the reason the patient had normal vitals is because it was a bleed, black stool, over a number of months. So your body kind of had time to compensate, and that's why the vitals were normal. So realize things do change. The waiting room is being monitored. So again, this patient's now being brought back for an initial lab.
Let your arm up. Thank you. All right, let's get you back to the waiting room.
What? No.
Yeah.
No, all I've been doing is waiting. I'm supposed to see a doctor now.
Soon, I'll let you know.
This is a fucking joke.
Yeah, it's good to laugh.
Laughing our way to being a third world country. Remind you of home?
Okay, no, we're not supposed to pick favorites here. I'm gonna keep my eye on you.
Yeah. You do that.
Oh, yeah.
So obviously what the patient said was inappropriate, but this does happen. Sometimes patients can say some very mean things to staff. Episode 2 actually spoke about how some patients will cuss and swear, yell at nurses, yell at the secretary. They'll complain, even calling 911 from the waiting room, saying they needed brought back faster. With the patient not realizing a child was undergoing CPR for an hour and 30 minutes, trying to save their life, and the staff was tied up with this case. So patients often have no clue as to why the wait is so long. They don't get to see the other side of things. I really hope that this medical drama continues to show that to potential future patients that are watching this.
What's going on?
Hypoxic to 78, BP's crashing, systolic's 82.
Pulse is thready. I should intubate. Does he need a massive transfusion protocol?
No.
So far, this resident is almost on the dangerous side of things. She does not know what she does not know and is not asking questions. Remember, she never let her senior resident know about the pneumothorax or the BiPAP. The patient's now crashing, hypotensive, tachycardic, hypoxic, and minutes from death. And she immediately states, I should intubate them. No. She keeps jumping to assumptions one after another, guessing without asking questions. And this could be extremely dangerous. So here she states we should start the massive transfusion protocol, which is basically a large volume of blood product that we give secondary to hemorrhagic shock. Again, she's just guessing and throwing out random things, and this is dangerous. Again, she is guessing here. The patient's not in hemorrhagic shock at this point from blood loss. The patient is menaced from death because he's in obstructive shock from a tension pneumothorax. Also, if you just give blood product and don't treat this, the patient's going to die. We have to fix the underlying cause. Again, she keeps jumping to assumptions and guessing without asking questions. The fact that she continues to spout all these things off tells me she knows nothing about this case, absolutely nothing about this case. At this point, this is where, as a senior resident, you actually tell the intern, step down, step aside. You're going to take control of this patient as the primary resident for the safety of this patient. Safety is everything here. And I've had to do this before. It's uncommon, but this does happen. And there's a professional way to go about this as well.
Absent breath sounds on the left. Tracheal deviation to the right. 14 gauge angiocath. Now, put him on a non-rebreather.
What are you doing?
Tension pneumothorax from the BiPAP's positive pressure.
So the patient now is a tension pneumothorax from the BiPAP positive pressure. So some clinical features you can see with the tension pneumothorax include absent or diminished breath sounds on the same side as the pneumothorax. So in this case, it was the left side. You're going to see hypotension, distended neck veins. A later sign when you have basically an impending cardiac arrest is when you have tracheal deviation, which the patient does have in this case. Now, basically what's happening here is the continuous entrance and entrapment of air into the pleural space so that all the structures in the mediastinum start to shift. In this case, they would be shifting to the right because of the increased pressure.
You hear that?
The patient ultimately needs a chest tube, but they need decompression in the meantime, otherwise they're going to die. Currently, that patient has a tension pneumothorax. They're in obstructive shock. The mediastinum is shifting to the other side because of the pressure buildup. What we need to do at this time is place a 14 gauge angiocath, mid-clavicular line, second intercostal space. You're actually going to hear a rush of air, and that's actually relieving that pressure. And what you're doing is you're preventing, any further movement of that mediastinum shifting, and you're actually causing it to shift back. And so you're returning that tension pneumothorax then to a simple pneumothorax. And at that time, now we have some time that we can place a chest tube.
Who the hell ordered BiPAP, Garcia?
No, his sats were down. I did.
Here she states the patient's sats were down. Remember, this patient was on 5 liters and the respiratory rate was normal at 16. All this patient needed was additional oxygen, or in this case, a non-rebreather.
You did, without running it by me.
So I love this scene because what the senior resident did is perfectly appropriate. He tries to tell her that what she did was not run it by him. And instead of recognizing her mistake and apologizing, the intern becomes more concerned about a chest tube. Now to the intern, if you're going to do this many things wrong, if you're not going to understand the case, what your decision, potential consequences have, what your decision, could result in, you're not going to be rewarded with putting in a chest tube here. Patient safety comes first, and the intern's going to have to step aside.
Can I put in a chest tube?
He doesn't need a chest tube. He needs a pigtail catheter.
So small critique here. He states the patient does not need a chest tube. They need a pigtail catheter. Again, small detail here, but a pigtail catheter is a type of chest tube. This was likely just a mistake in translation when the script was reviewed. Again, a pigtail catheter is a type of chest tube. So does the patient need a chest tube? Absolutely. I think what the intern was actually referring to here was a 28 to 32 French standard chest tube, which she would have stated, hey, can I put in a 28 French chest tube? This is more for a trauma setting. And that would have been a more appropriate question. However, given this is a simple pneumothorax at this point, they just needed a chest tube, but specifically a pigtail catheter chest tube. So again, I think this was more with just translation with the script itself. Again, a pigtail catheter is a type of chest tube, just much smaller.
And I'll be doing it.
Sats and pressure both coming up.
So the scene overall is very accurate in terms of how the senior resident is approaching this case and his response to the intern. I've had to do this exact same thing before and ask the intern to step aside, and I'm going to take control over this case, or the attending is going to take control over this case. And, we're just going to talk about this later. So kind of on the side, we'll just review everything. So this intern at this point is rather dangerous in this case. So at this point, it's best that she just step aside for the time being for patient safety, and we're just going to talk about the case later.
Draw up 75 of ketamine.
I think at this point, the intern kind of realizes, what happened. She's starting to realize what she doesn't know, and that all of the random things that she was spouting off was just wrong. Just looking at her facial expression, and now she doesn't have anything to say, we can kind of gauge that mindset a little bit. Again, we all make mistakes in training, but nobody will ever fault you for asking a question on something that you're not 100% sure on. In my training, I ask plenty of questions. The more questions you ask, the better. The more you don't know, the more you have to ask. Just like in episode 1, we talk about a few of the reviews on patients that present and not necessarily forthcoming of information, but at the same time, let's say they come in unresponsive. The more that you don't know, the more that you have to ask.
Whoa, what did I miss?
A little drama from attention pneumo.
You could have called me.
We got under control.
Good.
And Dr. Santos learned what can happen when you put a patient with a small pneumothorax on BiPAP. Thumb scalpel.
He was hypoxic. I thought it would help.
But you didn't discuss it with me, and he almost died. Dilator. You need to run every order by a senior resident or attending.
That's why it's a 4-year program.
Now, when you do this procedure, you want to make sure to never, ever lose this guide wire. If that gets sucked in the chest, you're screwed. Now, ready for the pigtail.
So I absolutely love this scene with the pigtail catheter chest tube. I think this is terrific. I think this is very accurate. And so the kit that I use in the ER is called a Wayne pigtail catheter kit. So let's talk about that kit a little bit. Let's kind of go through some of the process of putting in this chest tube. So for this procedure, we're going to start off by cleaning the left lateral chest, draping the patient, providing local anesthetic to the region. So the procedure is done at the 4th to 5th intercostal space, anterior mid-axillary line. I'm going to put a picture of that on screen so you can kind of get an idea of where that's at. The anesthetic is applied not just to the skin on top, but it's applied down to the pleura as well. The introducer needle is then inserted with a syringe attached to it. It's slowly advanced, pulling back on the plunger till we get air bubbles, and we know that we're in the right space. When we are in that space, we disconnect the syringe, leaving the needle. We then slide the guide wire through that needle into the chest, and then we take out the needle itself. So all you're left with is essentially the guide wire in the chest. The dilator is then advanced over the wire into the chest itself, and it kind of opens that. It allows enough room for that pigtail catheter to then slide over, and we remove the dilator. Next up, the straightened Wayne catheter chest tube is placed over that guide wire and slid into the pleural cavity. The guide wire and obturator are then removed. The catheter itself is then connected to the catheter tube with a stopcock and attached to a water seal suction apparatus. So in this case, it's important that after we put that in, we're also suturing it, we're bandaging everything, we're making it look nice, but we're getting an x-ray after that. We're doing the x-ray because we want to ensure successful placement of that pigtail catheter chest tube and then resolution of that pneumothorax. So in the case of this TV show, obviously I don't expect them to do a chest x-ray. I expect maybe they'll throw an ultrasound on there, but at least with this, we're gonna get a chest x-ray afterwards.
What the hell are you doing? Pneumo is tiny, it'll resolve spontaneously.
Yeah, it was tiny until the patient went on BiPAP.
Are you fucking kidding me?
Guide wire out.
His sats were down. I gave the order.
Without clearing it with me.
Honest mistake from the rookie. That's how we learn.
So we actually gauge a lot of information from this scene. When we look at the senior ER resident and we look at the surgery resident based on the comments, based on what she said, you start to realize there was probably something very similar that happened even between the two of them when they were younger in their training. So emergency medicine residency is 3 years, and some programs are 4 years. Mine was 4 years. General surgery residency is 5 years. So let's say he was an intern, right? That would put her either at a 2nd or a 3rd year surgery resident, assuming she's a 5th year surgery resident now, assuming she's a surgery senior. So in this case, likely something had happened before that is she's reminded of it, he's reminded of it, and they kind of share that look.
If she knew everything, she'd be your attending, not an intern.
That is very true.
Besides, it could have happened on its own without the BiPAP.
Wow, beautiful moment. A lot of love in the room.
If you'll excuse me, nice save.
So again, this is a teaching hospital, and some residencies are 3 years, some are 4 years for emergency medicine. So again, there's going to be plenty of learning, constant learning every single day, 80-hour weeks. This is pretty normal. You're going to be seeing lots of teaching here, and you're going to be learning every single day.
Jenna, I have some people here to see you. Hello.
Oh my God, you're okay.
So sorry. I have no idea how this happened. I swear. Is she,
Yes, she's cleared medically. You may take her home. Here are some discharge instructions, but no more pills unless they're from a doctor or pharmacy.
So the Xanax overdose laced with fentanyl is now deemed stable for discharge. Family is now here to take her home. Now, for these overdoses, after that observation period, we just want to make sure the patient has a reliable and safe ride home. So again, we've observed them for a number of hours. In my case, I like to observe for 2 hours. Again, I've had to redose Narcan at 30 minutes. I've had to redose Narcan at an hour. I've had to redose Narcan at an hour and a half. So again, it's very different, and it also depends on what the patient did. I've also had patients that have taken a fentanyl packet or a heroin packet and inserted it up their rectum because they're trying to hide it. They came in after an overdose, got Narcan, they're fine, you're watching them, and then all of a sudden you get called to the room because the patient went unresponsive. That drug packet actually ruptured. And so in this case, you're giving Narcan, you're doing all these other things. So realize some patients do require a longer observation period. Some patients, require that 2-hour observation period. I'm sure every physician kind of has their go-to observation time. I like 2 hours minimum myself. And then after that, we just want to make sure that the patient has a reliable and safe ride home. In the case of the drug packet that we talked about, those are much different stories. Those patients have a whole different workup. Those patients get admitted, and there's a number of consults that see that patient. So much different story, but just to kind of recap, at least with this particular episode, again, after the observation period, we just want them to have a safe and reliable ride home.
I won't. We're giving you some fentanyl test strips. These work on pills and liquids, and this is a Narcan spray. Please just keep it in your purse, just in case. If you're at a party, someone's out of it.
Yeah, thank you. You realize how lucky you are, yes?
Yeah, I do.
Now, none of the ERs I work at, we give boxes of Narcan spray out, but we do have a free Narcan dispenser outside the ER that's pretty normal. And you'll notice numerous ERs across the country where you'll have an actual Narcan vending machine dispenser, and this is free. Patients can take them as needed. Family can take them as needed. You can come in, grab a Narcan box, and leave. It's better to have it just in case. Some of the patients that I've had that come into the ER after an overdose, it was actually the friends, the family, a loved one that administered the Narcan kit they got from the vending machine that saved their life prior to EMS coming in. I actually had one person the other day that said they got their Narcan kit for their family member off of Amazon. Because initially I was like, oh, did you get it from one of the vending machines? No, they actually got it off Amazon. So you can actually get Narcan on Amazon. So I thought that was very interesting.
It's Wheeler. Dr. Abbott said to come back at 6:30 and he'd still be here, but we overslept. I forgot to charge my phone. I'm really sorry.
Okay, let's see.
Wheeler, Kristen?
It's Christy, and I'm her mom.
Dr. Abbott went off duty at 7, but that's no problem. We'll get you back. Have a seat until we call your name.
Okay, thank you so much.
You're welcome. Next.
How you guys doing?
And thanks. We missed our appointment, but otherwise, we're fine.
Oh, no.
Have you been here long?
I've been here about 4 hours.
Oh. We were here 2 nights ago. We waited 7 hours.
It's all bullshit. Can't believe somebody hasn't died out here.
So for this next case, I actually had a few people reach out because they were wondering how I was going to cover the material, what I was going to talk about. And so this is going to continue into the next episode as well. So I did fast forward just to take a look at all the different aspects of this. I wanted to try to find out where they were going with this before I talked about it. So in this case, a patient's coming in and her presumed mom. Now later we realized this was another family member. So there's a lot of different dynamics there, and I don't want to focus on that because it's going to kind of take away from some of the larger aspects of this. Here, a patient and her mom come in during the day shift. They would have came in during the night shift to see Dr. Abbott, but because of the time or whatever happened, they're coming in during the day shift.
So sorry to keep you waiting. I'm Dr. Heather Collins. You must be Christy and Lynette Wheeler? Yes.
Yes, we were supposed to see Dr. Abbott.
Yes, Dr. Abbott is an amazing physician, but even he needs sleep occasionally.
I guess I just got tired and I forgot to charge my phone and we overslept.
I use an old-fashioned alarm clock since med school. Never fails.
That's what I have at home. I just forgot to bring it.
Okay. I see we're doing a medication abortion today, correct?
Yep.
Well, since I didn't initially assess you, do you mind if I ask a few questions? Get up to speed?
No.
Thanks. Is this your first pregnancy?
Yes.
And you're 17? When did your last menstrual cycle start?
Not exactly sure. End of June. 23rd, maybe?
Any allergies to medication?
No.
Any surgeries in the past?
No.
So here we learn that the patient is in the ER to undergo a medication abortion, and that's all we know at this point. Since this was not the initial doctor that saw the patient, she has to ask basically all the same questions the patient was already asked to determine if this is a candidate for this. And again, based on the history, the symptoms, any contraindications, based on a bedside ultrasound. There's so much that goes into this. Again, we're going to talk about that a little bit more in the next episode, but that's completely appropriate in terms of the questions that she has to ask here. Sometimes patients don't like us asking the exact same questions again. You know, they got seen by one doctor, asked all the questions. That doctor actually signed out to the next doctor, and now that second doctor is taking control of the case. And sometimes they're going to repeat all the same questions. So this does happen. In this case, you know, obviously some similarities, some differences, but because she didn't actually see that patient, you know, she can't administer a medication or do any of these things without doing her own assessment.
I need to do another quick ultrasound to make sure everything's okay for the medication. Do you want to put on a gown to make sure you don't get gel all over your clothes?
Okay.
I'll be right back.
Thank you.
So next up, the resident's going to do a bedside ultrasound to get an estimated gestational age, or EGA. Now, this was already done during the night shift as well, but again, a new provider has seen this patient, so she's going to do a new bedside ultrasound. Now, I will say, if they would have had a formal ultrasound already done by an ultrasound technician, then that would have officially been read by the radiologist. It would have had a radiology impression. It would be in the patient's chart, and she wouldn't actually have to repeat this. Again, this was probably likely a few hours, you know, after the initial one. But again, it seems like no formal ultrasounds are done in this season at all, and really no portable x-rays are done. And so again, that's my critique with this. Again, we're not doing any formal ultrasounds by an ultrasound technician. We're not doing any portable x-rays so far. And this is just unrealistic for the size of this hospital, for the size of this trauma center and their capabilities. At a teaching hospital, you're going to have the ability to do these things. And I think we consistently we consistently don't see them. And I think it's just not realistic. So we're actually going to take a brief pause now, and we're actually going to go through some of the comments that I received on the first 3 episodes so far. We're going to start doing that every single episode. Just go through a few of these. So let's look at our first one. This is from Jonathan Meza T4C. I'm a combat medic in the Army, and I've learned a lot from your breakdowns of these shows. So thank you, Jonathan. From Jonah Perry 6103. Awesome review. Hope to see more of the show reviewed. Feel like I could get CE credits from your explanation. So I get that. Some of the reviews are way longer than the actual episode itself. This next one is from Daniel Lee CB1DP. Hello, I'm really loving all these reviews so far. I've just completed my interviews for medical school, and I'm hopeful that I'll be selected. Recently, I've been thinking about what branch of medicine I want to go into, and emergency medicine is piquing my interest. As an attending doctor, have you ever been in a situation, and he talks a little bit further. So the fact that this individual is, wanting to go into emergency medicine is terrific. I love it. Thank you for that. And this next one is from @14ER Skier. States, thanks from a first-year med student and an aspiring ER doc for making these. Definitely appreciate that. Thank you. This next one is from AJZEPP8976. I had a feeling this doc would, at long last, call out these absurd compressions. I can't believe how many others identifying as medical professionals on here are not mentioning this. This next one is from Q Monkey. Basically, they weren't happy that I spoke about CPR so much. Now, I did talk about the inaccuracies of CPR, and we did talk about it for a few episodes. States, please stop complaining about the CPR in this way. We get it. We understand they aren't doing it for real. And he kind of goes on to say, it's not about time. It's about practicality and safety. It's fine to point out that it's not accurate, but that isn't the goal with this particular aspect of the show. Again, that may not be the goal of the show, is to show the CPR, but that's actually my goal with the channel. So we're going to show the inaccuracies. We're going to show what's not realistic in the ER. Again, I'm an ER attending physician, and we're going to go through and we're going to show what's real and what's not. So we're going to detail, we're going to go in detail on these. We're going to critique these. Again, if you've been watching episode 1, 2, and 3, I don't let back. We're going to mention everything that I find that's unrealistic. And realistically, if I watched a few of these back, I'm probably going to see a few other things. So I'm going to try to mention what I can. When it does come to the CPR, though, I'll probably briefly put something on screen. I think we've hit that enough that I will shorten those explanations. But I do expect to see more Princess CPR.
Oh, you have everything?
Yeah, I think so.
Is that?
Yeah. Let's go, sweetheart. Wait, Mr. Bradley? I just wanted to apologize for the way I spoke to you.
Please, wait, please.
No excuse. I was gonna ask a nurse to give you this, but it's my number and email. If I can ever be of any help in any way, please.
I don't know who you are.
I'm sorry, I'm Jenna. I met Nick at orientation, and he was really sweet. We were in the same econ class, and we had this really big test coming up, so some of us made this kind of study group, and we'd stay up way too late, drinking coffee, and then have a really hard time falling asleep. And one girl said she knew how to get Xanax, but was too afraid to go pick it up. Nick was just being nice when he said he'd do it. I'm so sorry. I really hope he pulls through this. I'm praying he pulls through this.
He will.
Yeah, thank you. You should go. I'm sure your parents want to take you home.
So this was a very emotional scene. This was very realistic. The parents of Nick likely needed to hear this to provide some kind of closure to where the Xanax laced with fentanyl actually came from. Now, I've taken care of patients before, and it doesn't matter if it was a drug overdose or a motor vehicle crash. Let's say it's a car full of people that were doing heroin. They're all injecting heroin, some injecting heroin for the first time. But nobody in that car was able to call 911. They're all found unresponsive. They all come into the ER. And again, not all those patients may live. It has to do with how long they were down for, how much they injected, etc. So if you have, your ER team is trying to resuscitate them, and what you end up having is all of the family members of all these patients come in. And some of the family members may know each other. Other family members are seeing each other for the very first time. There can be arguments, there can be yelling. So you try to spread this out. And it works very similar with a car crash. You have, a hit and run or two cars hit each other. One passes away, one doesn't. And then you end up seeing both sets of family members in the trauma bay, and they start arguing with each other. So this does happen. This is very realistic. Again, in this case, obviously there's not that argument and things like that, but they're still meeting for the very first time. Now, I basically have 3 rules that I tell patients. So anybody that's contemplating drugs right now, these are my 3 rules. Number 1, don't do drugs. Number 2, if you choose to do drugs and you skip number 1, make sure that you have a buddy with you, someone to call EMS when you go unresponsive. Someone to give you Narcan if you go unresponsive, someone to call 911, somebody that's there to potentially save your life. And number 3, if you choose to do drugs and you choose to have a buddy, make sure that buddy is also not using drugs.
Hire scabs don't know zip ties from airline cable? Fuck around and find out. Come Monday, that promoter's gonna have my lawyer's shoe so far up his ass, he's gonna be flossing with the laces.
How we doing in here? Vitals are perfect. Setting 98 on 4 liters.
Nice. I could go back to work now.
With 6 rib fractures, a bruised lung, and a catheter in your chest, not the best idea. But I do respect the work ethic.
Richie, get Cecil on FaceTime again. I need to see this shit myself.
So mad respect for the work ethic here. It reminds me of a farmer I once took care of. He had an open ankle fracture dislocation. Literally the ankle was nearly hanging off. And he waited to come to the ER until he was done farming. He drove himself to the ER. Now, he required an emergent reduction in the ER. He required an OR washout. He was actually more concerned about the chores he had to get home to the next day than he was about the foot he almost lost.
A little jelly on the belly? Sorry, it's cold. And just to be sure you're not being treated for any blood clots, taking any anticoagulants?
No, I don't take any medicines.
Is everything okay?
Yeah.
So really my critique with this is that this is a trauma center in Pennsylvania that has access to a multitude of imaging modalities, including formal ultrasound. So the ACGME, the American College of Graduate Medical Education, mandates procedural competency for all emergency medicine residents in emergency ultrasound, as it is considered, in quotes, a skill integral to the practice of emergency medicine. So for general emergency ultrasound competency, a minimum of 150 total emergency ultrasound examinations are required. And so this requirement is over 3 years or 4 years, you're gonna have 150. Now, these are various body parts. These are different ultrasounds. Some may be renal, some fast, some cardiac. So my residency over 4 years, I did way more than 150, but that's the minimum. Now realize this is not a fellowship in ultrasound. This is just part of the educational curriculum. One of the core applications does include intrauterine pregnancy. Now, in all practicality, if it comes down to an estimated gestational age for a medication, just get a formal ultrasound. In reality, I would have ordered a transvaginal ultrasound to be done by an ultrasound-trained technician and certified technician. This is done in the ER. Sometimes they'll take them from the ER into another room to do these. The radiologist will then read the ultrasound, and an official impression is placed in that patient's chart. And what you're doing is you're kind of taking that burden, if you will, away, because now you have one doctor that got an estimated gestational age with a plus or minus on the days. You have another doctor that got it, and then we'll learn there's a third doctor. So you're having all of these different ages, and you're kind of putting yourself in a bind. Just get a formal ultrasound. My guess why they didn't get a formal ultrasound is that the hospital portrayed here does not have an ultrasound technician, which again, I highly doubt based on the size of the hospital being downtown and the fact that this is a trauma ER. This is a trauma center. So meaning producers, editors, consulting physicians choose not to get a formal ultrasound because it looks better to get everything done bedside for TV, right? We're doing bedside linear transducer. We're not doing x-ray. We're doing all of our own ultrasounds. We're not getting anything formal done. So we're actually going to talk about some of the estimated gestational age discrepancy values and such in the next episode. So I don't want to get too much into that. Again, at the end of the day, just get a formal ultrasound. In this case, you had numerous physicians that got an age. And again, there's a discrepancy there. There's going to be, for example, 10 weeks plus or minus 3 to 5 days, 9 weeks and 3 days plus or minus 3 to 5 days. Like you're going to have that. When you get a formal ultrasound, you're going to get your number and then you're going to get the plus or minus. And so what we go with essentially in that ER is we're going to go with that first number. So, baby is, this is 11 weeks and 2 days plus or minus 3 to 5 days. That's 11 weeks and 2 days. That's the number that we're going with. And then that level of discrepancy isn't going to change the medication administration. So again, at the end of the day, just get a formal ultrasound. So here we actually get another glimpse of the waiting room. Still massive, still long waits. Again, remember, patients don't stop coming to the ER. Now, we don't do this, but I would love to see a show of hands in the waiting room asking some very specific questions. How many did not call their PCP today? Raise their hand. How many did not follow up with the specialist that was given to them on the last visit? How many did not take Tylenol or Motrin before coming in to prove to us that you have a fever? How many are here for a work note? How many are here for a second opinion after seeing their specialist but not believing them? How many are here for stronger pain meds for a chronic issue? How many are here because you have the day off and your primary care doctor could not get you in? The amount of hands raised here would be alarming to non-medical people, but anybody in healthcare would not be surprised at all about the hands raised. So this is that same patient we keep seeing throughout all the episodes. He's made an appearance now in the first 4 episodes. So I really hope that this is leading to something, that this is going to be like a great case or a great teaching case. I really hope they're going to do something with this.
Vacuum twice a day, warm soaks. We'll see you here again in 2 days for a wound check. Got any questions?
Oh, hey, I need a gurney here!
Now! Gurney!
So episode 4 finishes with a gentleman that was waiting in the waiting room and started seizing. At that point, everybody is responding, and he's going to get brought back immediately. Another awesome episode. This concludes the episode 4 critique. I will say overall, while not 100% accurate, I firmly believe it's the most realistic medical drama on television. So far, I highly recommend the PITT. If an ER medical drama can make an ER doctor feel like he's at work on shift, then you know it's a good medical drama. Let's move on to the next critique.